Welcome to this Step 2 clinical knowledge review on ear, nose, and throat disorder test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for ear, nose, and throat topics, and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize patterns and apply test-taking strategies. Make sure you have reviewed the ear, nose, and throat and neurology sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for epistaxis, sinusitis, vertigo, and hearing loss. Second, we will apply specific strategies for each of these question types. And third, we will master the next best step question format for diagnosing and managing common ear, nose, and throat conditions. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy focuses on epistaxis, or nosebleeds. When you see a nosebleed question, immediately determine whether it is anterior or posterior. For anterior epistaxis, look for a young patient, dry climate, nose picking, or digital trauma. The bleeding comes from the Kiesselbach plexus on the anterior septum. Management starts with direct pressure and topical vasoconstrictors. For recurrent cases, silver nitrate cauterization is the next step. For posterior epistaxis, the clues are an older patient, hypertension, anticoagulant use, and profuse bleeding that is difficult to control. Posterior bleeds come from the Sphenopalatine artery and often require posterior packing or balloon tamponade, and these patients typically need hospital admission. The boards love testing this anterior versus posterior distinction, so make it your first mental framework when you see a nosebleed question. Strategy 2 is about distinguishing acute from chronic sinusitis, because the boards test management decisions based on duration and severity. For acute sinusitis, the duration is under 4 weeks. Most cases are viral, and the boards want to know when to give antibiotics. The key triggers are symptoms that worsen after 5 to 7 days, which is called double worsening, or symptoms that persist beyond 10 days without improvement. First-line antibiotic treatment is amoxicillin or amoxicillin clavulanate. For chronic sinusitis, the duration is over 12 weeks. Think about underlying causes like allergies, nasal polyps, and anatomic obstruction. But the real high-yield material here is complications. Orbital cellulitis presenting with proptosis and vision changes is an emergency that requires immediate intervention. Cavernous sinus thrombosis with bilateral eye findings and cranial nerve deficits is another classic board complication. Know these danger signs because they appear frequently on the exam. Now let us go through high-yield stem recognition for the 3 types of vertigo you need to know for the boards. For benign paroxysmal positional vertigo, the classic stem describes brief episodes of spinning lasting seconds, triggered by head position changes like rolling over in bed or looking up. The Dix-Hallpike test will be positive with upbeat torsional nystagmus. Treatment is the Epley maneuver. There is no hearing loss or tinnitus. This is the most commonly tested vertigo type. For Meniere disease, look for the classic triad of episodic vertigo lasting minutes to hours, low-frequency sensorineural hearing loss, and tinnitus with oral fullness. Treatment is salt restriction and diuretics. Audiometry will show low-frequency hearing loss. For vestibular neuritis, the stem describes acute onset of severe persistent vertigo lasting days, often following a viral illness. The key distinguishing feature is no hearing loss, which separates it from labyrinthitis. The head impulse test is positive. Treatment is vestibular rehabilitation. These stems repeat over and over on practice exams. Let us work through our first practice question. A 14-year-old boy presents with recurrent episodes of nosebleeds over the past 3 months. The bleeding is always from the left nostril and stops with pressure within 10 minutes. He has a history of allergic rhinitis and frequently picks his nose. On exam, an anterior septal vessel is visible and actively oozing. What is the most appropriate next step in management? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. Young patient, recurrent anterior nosebleeds, visible septal vessel, history of nose picking and allergic rhinitis. This is classic anterior epistaxis from the Kiesselbach plexus. The visible oozing vessel confirms the bleeding site. Step 2. Apply the rule. For recurrent anterior epistaxis with a visible vessel, silver nitrate cauterization is the definitive outpatient treatment. This is a commonly tested management step. Step 3. Eliminate wrong answers. Posterior nasal packing is for posterior bleeds that cannot be controlled with anterior measures. This is clearly an anterior bleed. Emergent surgical ligation is reserved for life-threatening hemorrhage, which this is not. Computed tomography angiography is not indicated for a straightforward anterior epistaxis case. The correct answer is C. Silver nitrate cauterization. Here is our second practice question. A 35-year-old woman presents with 10 days of worsening facial pressure, purulent nasal discharge, and low-grade fever. She initially had a viral upper respiratory infection that seemed to improve after 5 days, but then worsened. On exam, there is tenderness over the maxillary sinuses. What is the most appropriate next step in management? Think about this one carefully. The key is the timeline and the pattern of symptoms. We will walk through the answer next. Let us work through this answer. First, read the question carefully. This describes a classic double worsening pattern. The patient had a viral upper respiratory infection that initially improved and then got worse after day 5. This pattern, combined with purulent nasal drainage, facial tenderness, and over 10 days of symptoms, meets the criteria for acute bacterial sinusitis requiring antibiotic therapy. Now, why are antibiotics indicated here? Amoxicillin clavulanate is the first-line antibiotic for acute bacterial sinusitis. Imaging with computed tomography is not needed for uncomplicated acute sinusitis. Nasal cultures are reserved for cases that do not respond to initial therapy. Intranasal corticosteroids alone are insufficient when bacterial infection is suspected based on the double worsening pattern. The correct answer is C. Amoxicillin clavulanate. Let us review hearing loss for the boards, because tuning fork tests come up constantly. For conductive hearing loss, air conduction is impaired but bone conduction is intact. The Weber test lateralizes to the affected ear, and the Rinner test shows bone conduction greater than air conduction on the affected side. Common causes include otitis media, cerumen impaction, otosclerosis, and tympanic membrane perforation. A high-yield pearl. Otosclerosis is the most common cause of conductive hearing loss in young adults, and it classically presents with progressive hearing loss and a normal-appearing tympanic membrane. For sensorineural hearing loss, both air and bone conduction are impaired. The Weber test lateralizes to the unaffected ear, and the Rinner test shows air conduction greater than bone conduction on both sides. Common causes include presbycusis, noise exposure, Meniere disease, acoustic neuroma, and ototoxic medications like aminoglycosides. Remember that sudden sensorineural hearing loss is treated urgently with systemic corticosteroids, and this is a board favorite question. Here is our third practice question. A 42-year-old man presents with a 3-month history of recurrent episodes of severe spinning dizziness lasting 2 to 4 hours. The episodes are accompanied by a roaring sound in the right ear, a sensation of fullness, and decreased hearing on the right side. Between episodes, he feels well. Audiometry shows low-frequency sensorineural hearing loss on the right. What is the most likely diagnosis? This is a classic pattern recognition question. Think about the duration of the episodes and the associated symptoms. We will walk through it next. Let us break down this answer. The classic pattern here is episodic vertigo lasting hours, low-frequency sensorineural hearing loss, tinnitus described as a roaring sound, and oral fullness. This is the Meniere disease triad, with oral fullness making it a tetrad. The key is that the episodes last minutes to hours and come with hearing symptoms between normal intervals. Now the key distinctions. Benign paroxysmal positional vertigo causes brief episodes lasting only seconds, triggered by position changes, and there is no hearing loss. Vestibular neuritis causes a single prolonged episode lasting days, not recurrent episodes, and importantly, there is no hearing loss. Acoustic neuroma causes gradual unilateral sensorineural hearing loss, but typically presents with constant imbalance, not episodic vertigo. The correct answer is B, Meniere disease. Here is a critical test-taking pearl about tuning fork tests and hearing loss interpretation. For the Weber test, place the tuning fork on the forehead. In conductive hearing loss, sound lateralizes to the affected ear because ambient noise is blocked and bone conduction is perceived louder. In sensorineural hearing loss, sound lateralizes to the unaffected ear because the good cochlea perceives it better. For the RIN test, compare air and bone conduction. In normal hearing and sensorineural loss, air conduction is greater than bone conduction. In conductive loss, bone conduction is greater than air conduction on the affected side. Here is the quick shortcut that many test takers use. In Weber, conductive loss goes to the bad ear. Sensorineural loss goes to the good ear. For Rinner, the only abnormal result is bone greater than air, which always means conductive loss. Audiometry is the gold standard for confirming the type and severity. Review these patterns in your question bank because they appear on nearly every practice exam. That wraps up our review of ear, nose, and throat disorder test-taking strategies for Step 2 clinical knowledge. Remember to review the ear, nose, and throat and neurology chapters in first aid and your question bank. Focus on epistaxis management algorithms, sinusitis treatment criteria, vertigo differential diagnosis, and hearing loss evaluation with tuning fork interpretation. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.